So I'm going to start my IC on keratoplasty clinics, and I welcome all the faculties who are already joined and will join in some time. And the first talk will be by Dr. Sudhang Bharti, and he'll be speaking on choosing the correct surgical technique of corneal transplantation and regarding penetrating keratoplasty in today's scenario.
Thank you, Dr. Bhupesh, for giving me this opportunity to join in this very interesting and promising instruction course in the. And I'll start my talk. And
Sir, just a quick question. How much time are we giving to each presenter?
So first speaker will be around 12 minutes, rest will be 10 minutes.
Okay. Any discussion time or any question answer time?
That we'll see. If any questions is there, we'll take after the talk. If not, then end of the session.
Okay, thank you.
So I'll start my talk on choosing the correct surgical technique of corneal transplant. And seventh leading cause of blindness worldwide and second most common cause in developing countries is corneal blindness. And approximately 10% of the corneal blind patients can be treated with keratoplasty. So that's a very important number. That lot of success in recovering the vision is there with the keratoplasty. The causes of corneal blindness, preventable causes are like keratitis, trauma, nutritional blindness, trachoma, and bullous keratopathy. And non-preventable causes are like corneal dystrophies, degenerations, and congenital corneal opacity. Various methods of keratoplasty, corneal organ transplantation remains the mainstay treatment for patients with corneal blindness. And penetrating keratoplasty is the gold standard, involves full thickness corneal transplantation. Lamellar keratoplasty is a partial thickness corneal transplant and depends on the pathology. And history of keratoplasty goes back, and father of keratoplasty is Filatov. And if we see what kind of keratoplasties we have in our armamentarium, the main is the full thickness and or penetrating keratoplasty, and second is the lamellar keratoplasty, which could be divided into anterior and posterior. Anterior lamellar is superficial anterior lamellar keratoplasty and deep anterior lamellar keratoplasty, which is pretty common for the anterior lamellar keratoplasty. And for the posterior lamellar, it is DSEC or DMAC, depending on what kind of thickness we are using for the tissue. And so PK is full thickness, and DSEC is desmase plus posterior corneal stroma, and DMAC is the desmase only. And this is basically the most perfect keratoplasty, where the corneal clarity and curvature and everything becomes nearly as in a normal eye. So in the ALK, or the plane of stromal dissection is somewhere here, and then deep anterior lamellar keratoplasty is here, the gray line, and the desmase bearing DLK is leaving only desmase. So conventional DSEC is the thickness of the flap is about 170 microns. Micro thin DSEC is 80 microns, and DMAC, where only desmase is endothelial keratoplasty, then is thickness of the desmase, which is 20 microns. For penetrating keratoplasty, the indications are earlier graft failure, whether it was DSEC, DMAC, or any other type lamellar keratoplasties. Advanced keratoconus, where all the layers of the cornea is involved, infectious or non-infectious corneal ulcerations, bullous keratopathy with scarring and deep corneal scar. For DALK, initial keratoconus, deep stromal scars caused by herpetic or other infections, epithelial and stromal dystrophies, spheroidal degenerations, epithelial ingrowth after refractive surgeries. DSEC, when we have a desmoid stripping with an automated endothelial keratoplasty, is for graft failure infection, especially bullous keratopathy, corneal scar, Fuchs dystrophy, where the posterior layers are involved, and other endothelial diseases. And DMEC is a finest thin desmase transplant only, which is successful in cases of bullous keratopathy, Fuchs, and other endothelial diseases and dystrophies. The advantage of penetrating keratoplasty, it is very standardized and long experience is there. The disadvantage is that it leads to post-operative astigmatism. Sometimes it might be a very irregular kind of astigmatism. The visual rehabilitation is long, and long-term care is required, and allograft rejection is sometimes an issue. DALC, it is the faster visual rehabilitation and lower rejection rate, but it is a learning curve, and the complications are perforation of the desquamous membrane. DSEC also, the rehabilitation is very fast and lower rejection rate, and it does not cause any astigmatism. The possibility of irregularities in the interface and graft dislocation is a very concern. And DMEC, same as DSEC, but still better visual outcome and very low rate of rejection, but with the high rates of graft detachments. Penetrating versus endothelial keratoplasty. This is the penetrating keratoplasty, and this is the endothelial keratoplasty. The advantage is that endothelial keratoplasty, no suture-related astigmatism, and reduced risk of suprachoroidal hemorrhage. Role of DSEC over DMEC is DSEC is more indicated in cases where deep AC is there, high myopia, post-vitrectomy, and severe bullous keratopathy. DSEC seems to be a better bet as compared to DMEC, especially in cases where trabeculectomy or glaucoma drainage devices have been used. The complications are, endothelial cell loss is there in DSEC and DMEC up to 35 to 15%, and graft detachment is there in DMEC about 5 to 10% in good hands and maximum 20% in DMEC cases. The rest of the complications are nearly the same. For penetrating keratoplasty, there are indications where prognosis is excellent, like keratoconus or lattice and granular dystrophy. Where very good prognosis one can imagine is cases of PBK or ABK, herpetic or iridocorneal endothelial syndrome, macular dystrophy of the cornea. Category 3, where good prognosis is good or fair, is keratoglobus, pellucid marginal degeneration, congenital hereditary endothelial dystrophies of the cornea, and active microbial keratitis. And very poor prognosis in cases of neurotropic keratitis, failed graft, anterior segment dysgenesis, and ocular cicatricial pemphigus or Stevens-Johnson syndrome. So there the results are not so fantastic. Indications for penetrating keratoplasty could be optical or intraoperative DALC to PK conversion, therapeutic where the infection is there and you have to put another cornea, and in femtosecond penetrating keratoplasty. Preoperative assessment in all like any other surgery, but ocular surface evaluation is very important. Also the AC details, and The AIOC2021 pre-op assessment is depth of corneal opacities, anti-segment, and especially the anti-synechia, retrocorneal membrane, and corneal thinning we have to assess. Instrumentation is as simple. It's only suture and few good needle holders and forceps and corneal scissors. And preparation is, you have to keep hypotony and good peribulbar anesthesia. Some pediatric patient might require general anesthesia, painting, draping with a 5% povidone iodine. Trephines are handheld or suction trephines or punch systems and automated trephines. And also we have the non-mechanical trephine, which is femtosecond laser, which is excellent for making a beautiful round circular trephination. And donor trephination is always done before host corneal trephination, because once we have a donor which is fantastic, then we can go forward. If the donor is not, tissue is not good, or the tissue which is cut is not excellent, then we may not continue with the and donor sizing is about pediatric cases in anti-synechia and therapeutic cases oversized by about 1 millimeter. Normal adult cases oversized by about 0.5 millimeter, and keratoconus same size or 0.25, because the closure is very easy and very good. Host sizing for white to white up to 12.5 or so, 8 to 8.5 millimeter, or for about 11.5 or less, 7.5 to 7.75 millimeter, and larger graft in keratoconus and bullous keratopathies. So suturing is 90% of the depth of the tissue, and 4 cardinal sutures here, like here, and always the first one at 12 o'clock. And 4 cardinal sutures can be followed up by with the interrupted sutures, or combined interrupted and running, or running and double running, as you can see it, depending on what kind of closure you are getting. Femtosecond laser assisted penetrating keratoplasty gives us an option of all kind of possibilities of shapes, but the most common is the top hat or the mushroom, which gives absolutely fantastic applanation and closure of the donor and cornea. Complications are, there is possibility of perforation, damage to corneal, iris damage, AC damage, wound leak, and post-op astigmatism and graft rejection, and late post-operative complications, which have to be managed by both the...
Sir, sorry to interrupt you, but we have limited time for each presenter.
So I am on the last slide.
Okay.
The appropriate patient selection and written consent is a must, and proper wound apposition and post-op astigmatism can be reduced, and complications should be promptly recognized and appropriately managed. Thank you very much.
So any questions?
Rupesh, you're mute.
So any comments from the respected faculties? Rajesh sir, Himanshu sir?
So very nice overview, very nicely covered everything. And now we can go on to each procedure separately, and definitely we can have a discussion.
Yeah. So the next talk will be by Professor Rajesh Sinha from RPC, and Dr. Rajesh is a senior cornea surgeon and a fantastic anti-segment surgeon. We'll be speaking on anterior lamellar keratoplasty, past and present.
Oh, sorry. I really am thankful to Dr. Bhupesh for including me in this wonderful instruction course. I'll be talking about anterior lamellar keratoplasty. Now, anterior lamellar keratoplasty basically it includes a spectrum of surgeries which takes care of the diseases of cornea involving from the most superficial part to deeper down up to the desmaze level. So this is what is the whole part is considered as anterior lamellar keratoplasty. And for a desmaze bearing anterior laminar keratoplasty, a deep anterior laminar keratoplasty has been coined. Now, the indications for anterior laminar keratoplasty can be superficial corneal dystrophies, Salzmann nodular degeneration, keratoconus, granular dystrophies, ferrule degeneration, trachomatous keratopathy, superficial scars, etc. There can be more, and these are the common indications for which you do anterior laminar keratoplasty. So, superficial layer. If you have the most superficial opacity, you can manage it just by a phototherapeutic keratectomy, which is not actually a keratoplasty, but it does, need a mention because it takes care of the superficial corneal disorder. If you go further deeper down, like for 50 to 75 microns of stroma, you can ablate by phototherapeutic keratectomy and you can clear up the cornea and go ahead. But if it goes deeper down up to 150 to 200 microns, you can do a sutureless anterior laminar keratoplasty. If it's further deeper down, you have to put sutures, you have to go deeper down. So phototherapeutic keratectomy can be done by excimer laser, and it is really helpful in improving visual acuity, and it delays the requirement, or sometimes completely defers the requirement of any anterior laminar keratoplasty. So it really deserves a mention in this set of surgeries. So for this, it's a case of a band-shaped keratopathy wherein epithelium is debrided and then excimer laser is used to ablate the superficial stroma so that the opacity is removed, and then you clean it up, put a bandage contact lens, and that is it. And you can see here there are certain conditions which can be very nicely managed by PTK, like pre-op Rees buckler dystrophy, improving to this condition. Band-shaped keratopathy, 2 examples, improving quite significantly. A case of a pterygium involving the visual axis. After pterygium surgery, this was the scar left. So PTK was done and you can see the cornea cleared up completely. So it is really helpful in delaying or it's really helpful in deferring anterior laminar keratoplasty, thereby saving one tissue, and that can be utilized for any other case. So these are some of the studies. There are many more studies which have shown that PTK is quite useful in superficial corneal opacity. Now, if the opacity, as I said, goes deeper down, like up to 150 microns, etc., then in that case, a sutureless superficial anterior laminar keratoplasty can be done. Something in a case of a granular dystrophy, you can, earlier, what we used to do was either a laminar keratoplasty or a laminar keratoplasty with sutures or a PTK to remove the clarity, to improve the clarity in the central part of the cornea. But now, sutureless anterior laminar keratoplasty is a very good option which can clear up the opacity and the cornea can become very clean. This is an example, surgical example of a case wherein sutureless anterior laminar keratoplasty was done in a case of Salzmann nodular degeneration, ocular surface disorder. So the tissue, the donor lenticule has been fashioned, and this is the case of the trachomatous keratopathy. And if you have a small 1 or 2 these nodules, they require a manual removal. Once you remove it manually, and then you cut it with the microkeratome head. And after removing the superficial opacity, you can see how clear the cornea has become. And there is some amount of cataract in this. So you can very well do cataract surgery also, so that the visual rehabilitation is complete in this particular case. And once you have put the IOL, then you can just put air bubble in the anterior chamber, put the donor lenticule, and then dry the edges so that you can draw the fluid from the interface. And once you have done it adequately, then you can put fibrin glue at the edge so that the tissue remains there. This is just for the initial adhesion, and later on the tissue adheres well. And then after that, you put a bandage contact lens over it. So SALC is a very good procedure. This is another example wherein there was a corneal scar and SALC was done, and you can see how reasonably clear it has become. There are multiple studies, a study from our own center wherein SALC has been found to be very effective. Now, femtosecond laser has really revolutionized the refractive surgeries, and it has also worked a lot in cataract, in cataract as well as the corneal surgery. And this is an example of a femtosecond assisted anterior laminar keratoplasty. The idea is that you use femtosecond laser to create the dissection so that you get a nice dissection plane. And the advantage of femtosecond laser is that you get a flap kind of a thing, which is not a meniscus one, which is a planar one. So you have a vertical edge. So the adhesion, the alignment of the tissue is very, very good. Instead, when you use a microkeratome, wherein you get a edge which is sloping, a meniscus kind of a flap. So this is a case of healed keratitis where there was vascularization as well. So you can see that sometimes the femtosecond laser doesn't, penetrate fully in every area wherein there is an opacity. So sometimes you have to do a bit more effort in dissecting. Now, once you have dissected the tissue, you take the patient to the main OR, and then you remove this dissected tissue. You can see how opacified it is because of the scar, and then as you have dissected it already, so removing is very easy. The biggest advantage of using femtosecond laser is what I said, that the alignment of the edges is very good. It's a vertical edge, as you can see here. It is just to wash the blood, and then we dry it and then put the donor lenticule over it. In this particular case, because I had to dissect a bit, I had to do some more effort. So I could see a little bit of irregularity on the surface. So I'm just trying to, polish it a bit and then put a donor lenticule over it. Now, once it is there, you just dry the edges and put fibrin glue and then put a bandage contact lens over it. Bandage contact lens. And in these cases, I prefer putting bandage contact lens for a little longer period, like something like 3 weeks or so. And there are studies which have shown good results of femtosecond assisted anterior laminar keratoplasty. There can be some complications. There can be glue can go to the peripheral part of the edge. There can be a little bit of epithelial ingrowth sometimes, but mostly it stays in the peripheral part only. And sometimes you can get a little bit of haze. These complications can be seen. Yeah, I'll just move fast. So if the opacity is deeper down, you can do anterior laminar keratoplasty, which can be manual or automated. So if you are doing a manual, then you have to dissect it manually and then place a donor lenticule. And if you are using a microkeratome, then you dissect it with a microkeratome. And the advantage of doing a procedure with microkeratome, particularly in such cases, is that you can see I'm using a 250 micron head, a case of a trachomatous keratopathy with thinning, a little bit of thinning of cornea. After dissecting it, you can see you have a very uniform interface, and this is a scar which after dissection will become reasonably clear. These are the post-op picture, the clear interface. If this keratoglobus wherein tuck-in laminar keratoplasty can be done to strengthen the peripheral part of the cornea as well. And this is the post-operative picture. So tuck-in of the tissue in the peripheral part. I'll skip the deep anterior laminar keratoplasty, just as Dr. Fogla will be discussing about it. Just a final word about use of IOCT guided anterior laminar procedure. When you use intraoperative OCT, it is really helpful because it lets you know at what level you are working. So at what level you are dissecting. So that you get to know by lifting the tissue, you know how much residual tissue is left. And it also helps you to know that in one area, if you have more tissue and in the other area you have less, you can dissect accordingly, and you exactly know in real time that where is the extra tissue. Like if there's a ridge here like this, you can remove the ridge and a regular interface and clear up the tissue. So in conclusion, anterior laminar keratoplasty is a very useful tool for replacement of disease layer by a healthy donor tissue. If the disease is involving up to 200 microns, then you can manage it without requirement of any suture. But if it's deeper down, then you have to use more tissue, and for that you require sutures. So you can do a full lamellar keratoplasty, which can be automated, ALTK, or a deep anterior lamellar keratoplasty. Thank you very much for your patient listening.
Thank you, Professor Rajesh. It was a wonderful talk. I just have a small question. Sir, after doing FALC or SALC, do you perform refractive correction also later point of time?
See, you can do a PRK in such cases if everything is fine and the patient has some amount of refractive error. You can do a surface ablation in these cases.
Have you seen any cases of rejection post PRK in these cases?
I have done very few PRKs in these cases because most of them they are rehabilitated well with spectacles only. So as far as rejection is concerned, I'm yet to see after doing PRK in a FALC. It's a very small cohort, so maybe somebody else, maybe Dr. Fogla might be having some experience on any rejection following FALC, Dr. Fogla?
No, I haven't seen any rejection so far. Although there can be sometimes, especially patients who have pre-existing allergic eye disease, they can have some sort of stromal haze or stromal inflammation. So you may need to continue with topical steroids for a longer period of time.
Thank you, Professor Rajesh.
So haze is one, and sometimes little glue goes in under the peripheral part of the edge. That's what I have felt in a few cases. That is one thing which I felt. That too more in microkeratome one, not in FALC. FALC has a vertical edge. Apposition is very good.
Okay, thank you, sir. Thank you so much. So now the next talk will be by Dr. Rajesh Fogla. And Dr. Rajesh Fogla is speaking on deep anterior lamellar keratoplasty, bubble versus no bubble. Dr. Rajesh is an excellent teacher and an excellent surgeon and a great innovator, and he has changed the outlook towards DALC, at least in the Indian corneal surgeons. So over to Dr. Rajesh now.
Thank you, Bhupesh. I'll share some tips on surgical approach to successful DALC. No financial interest to disclose. We have already understood the concept of deep anterior lamellar keratoplasty, wherein the 90% of post stroma is removed and replaced by a donor tissue. And the biggest advantage is no risk of endothelial rejection. It can be performed for a wide range of indications where the endothelium is normal. There are basic two surgical techniques. There is one where you expose the pre-decimus layer, either by injecting stromal injection of air, viscoelastic or fluid, or you do a manual dissection, which is near decimus. In the pre-op evaluation, it's important that you look at the extent of the pathology, the corneal thickness, and especially the scar, whether it's superficial or is involving the deeper areas, and also look at the limbus to look out for any evidence of limbal stem cell deficiency. Corneal thickness can be assessed using any of the tomography devices or the anterior segment OCT. The anterior segment OCT also provides you in cross-section view how deep the scar is, whether it is involving the decimus membrane as well. The instruments that are required. In the original big bubble technique described by Anwar, 27 or 30 gauge needle is used for air injection, and this works quite well. However, if the needle is not placed in the right position, you have an increased risk of complication. Dr. Dua described the pre-decimus layer. So in a type 1 bubble, the separation is between the stroma and the pre-decimus layer, whereas in a type 2 bubble, the separation happens between the pre-decimus layer and the decimus membrane. And you also get a mixed bubble, which is a combination of type 1 and type 2. In the surgical planning, we already mentioned the importance of regional pachymetry. This helps defining the size of the trephine and the depth of trephination. You can have these guarded depth trephines, which have preset depths, or you can use the suction trephine, where each quarter turn cuts down a depth of 60 microns. Femtosecond laser has the advantage of providing customized shape to the edges of the incision. In certain cases, we also use the diamond knife for making the original groove. I prefer to debulk the cornea, but again, it's a surgeon's preferred choice. Debulking should be avoided if the apex is very thin. Debulking allows deeper placement of the cannula and also allows faster deflation of the big bubble. That's just to show if the needle placement is superficial, you tend to have a lot of superficial emphysema. And if it goes deep, you have an increased risk of perforation. So cannula is usually preferred. Now, after you have debulked, you go to the base of your trephination and then make a small stromal track. And then you introduce your cannula, either central or paracentrally, and you inject air to create the big bubble. How do you feel you're at the right place? A man will feel a sudden ease of resistance as you advance the cannula. You can look at the reflection of the cannula against the air bubble. If you keep the pupil dilated, you can see some wrinkles close to the resistance membrane. If you use pachymetry, you can make an initial cut going up to 95% depth so that your cannula is already very deep. You can use intra-op OCT or a femtosecond laser to create the track prior to injection. As you inject air, you will feel an initial resistance which gives way when the bubble starts forming. And then as the bubble is expanding, you feel the resistance again because the aqueous has no place to displace. And this rise in pressure within the anterior chamber also increases the pressure within the bubble, which if you persist to try and expand the bubble can end up in a spontaneous rupture. To overcome this problem, we described a sequential air injection technique where you initiate the bubble and after which you do a paracentesis to lower the intraocular pressure. And then when you enlarge the bubble, you're able to enlarge the bubble successfully without the risk of spontaneous rupture. Big bubble should be avoided in macular dystrophy and advanced keratoconus with extreme thinning and scars which are involving the Descemet's membrane. The bubble can be identified with a small bubble test where you can place a small air bubble and which remains in the periphery, and after you deflate, the bubble comes to the center. And as you release aqueous, you will find that the peripheral cornea becomes soft, whereas the central part, which has the big bubble, remains firm. You can also identify the big bubble using the intra-op OCT. Deflation can be performed after placing cohesive viscoelastic on the surface, which retards the egress of air, thereby allows a gradual deflation. You separate the residual stroma into 4 quadrants, and then you can excise it and taking care that you don't perforate the posterior layer. A type 2 bubble ideally should not be deroofed. And in this study, they have shown that there is an increased rate of conversion to penetrating keratoplasty whenever you try to bear the Descemet's membrane in a type 2 bubble. Donor Descemet's tissue is usually the same size in ectatic disorders. In other indications, it can be 0.25 to 0.5 millimeter larger. However, if you are doing a femtosecond laser-assisted DALK, you don't need that discrepancy because the apposition is really good even with the same size graft. You can remove the Descemet's membrane if using older tissues. In younger tissues, you can even place it without removing. Suturing technique is the same as penetrating keratoplasty, just that you take slightly longer bites. And on the donor side, it's about 80% depth, and on the host side, you go 90% so that you get a good graft-versus apposition. That's the post-operative outcome. A femtosecond laser, Rajesh has already mentioned the advantages. That's the post-operative outcome, showing you a good apposition and a great outcome. The refractive outcome is very good as long as the sutures are in place. However, post-suture removal, even the femtosecond DALK can have unpredictable astigmatism. The other option is to do a visco bubble. Instead of air, you can put in a cannula at 80 to 85% depth and then inject cohesive viscoelastic to achieve what is called as the visco bubble. In this scenario, it's always better to do a paracentesis first, release some aqueous so that there is reduced counter pressure, which makes it easier to achieve the visco bubble. If you have a failed bubble, you may have to fall back on doing a manual technique. In the manual technique, basically you are doing a deep trephination followed by a debulking, initial debulking, after which you make a peripheral pocket, and you can use scissors to make this groove. I have designed an instrument which is called the pocket forceps, with which you can go circumferentially to create a groove which is then opened up. And the rest is something similar to Malbrand's peeling technique, where you peel off the anterior stroma. This helps you achieve a good deep plane. This can also be done in failed big bubbles. This is a case of hydrops where you can see the manual DALK, and you can see there's hardly any residual stroma, and measuring only about 30 microns on anterior segment OCT. Instead of using fresh donor tissue, you can even use gamma irradiated lenticules for anterior lamellar keratoplasty, which gives equally good results. Post-operatively, common complication can be a double anterior chamber if you have encountered any microperforations during the surgery. Can be managed by using a gas or air bubble. Important to prevent pupillary block, either keep the pupil dilated or do an inferior paracentesis and do a inferior peripheral aerodectomy. In decision making, yes, this flowchart is very useful. You do a clinical examination, do a tomography, anterior segment OCT. If there are no stromal scars involving the decimus membrane or the predecimus layer, and the apical thickness is more than 200 microns and the steep K is less than 70 diopters, you can then schedule the patient for a big bubble technique. And in that, if you achieve the type 1 big bubble, you can go ahead. But if you achieve a type 2 bubble, or if you have a microperforation, you have to move on to doing a manual DALC. There also, I think if you achieve a smooth bed with a residual bed of less than 80 microns, you can have reasonably good outcomes. So in conclusion, DALC should be considered the procedure of choice for corneal diseases with healthy endothelium. Surgical techniques continue to evolve, ensuring greater success of big bubble DALC. Pre-op evaluation and surgical planning is essential to minimize complications. In future, the femtosecond laser technology and the intra-op OCT may further improve the outcomes, making it easier for surgeons to transition to performing a DALC surgery. Thank you. Thank you for a patient hearing.
Thank you, sir. It was a wonderful talk and wonderful surgeries. And any questions from any panelists? Himanshu, sir, any comments for Professor Fogla?
I mean, he is the one who teaches us everything every time. And whenever you see his surgeries, you're spellbound. You always keep on learning. Even if you see his surgeries every day, you keep on learning every day something new.
I completely agree with Dr. Himanshu. I had one query, Dr. Fogla, that you said that, when you inject the bubble in the anterior chamber, you first initiate the bubble, the big bubble. When you inject air in anterior chamber, you first initiate it. So is there an advantage? Like what I do, I do a little bit of paracentesis and then inject air in the anterior chamber and then go ahead with. Or if I have to do a dissection first and then create a bubble, then I do a dissection, then inject air and then go for a big bubble.
It is perfectly fine. If you do a paracentesis first, and then when you inject air, the counter pressure that is exerted by the aqueous, that is lost. So what happens is, when the big bubble formation starts, by the time you stop injecting air, the bubble sometimes has already expanded beyond its limit and can have a rupture. The second thing is, you don't know whether you're getting a type 1 or a type 2 bubble. Type 2 bubble can initiate from the periphery as well. And if you have made a paracentesis, there is already a break in the periphery. So what happens is, sometimes the type 2 bubble will start, it will go to the area of your paracentesis, and then you can have a rip in the decimals. So in my technique, when you initiate the bubble, there is resistance because the aqueous cannot get displaced because you have not made a paracentesis. But once the big bubble is initiated, then you don't have to worry. You can stop and inject air. Subsequently, it will go in the same plane. So if you make a paracentesis, lower the IOP, the counter pressure is reduced, and then you find that you can enlarge the bubble to the desired size. Otherwise, often surgeons make the bubble going only up to 6.57 millimeter, but the trephination is 8 millimeter. Then in the periphery, you have a ridge of stroma, and then sometimes when you try to dissect that, you end up creating perforations.
Okay.
Thank you, sir. And the next talk will be Dr. Himanshu Matalia. And Himanshu is my mentor and my teacher. And he'll be speaking on DSEC and its significance in the era of DMAC.
Thank you, Bhupesh. Am I audible? My slides are visible?
Yes, sir.
Yes, sir. Perfect. Thank you. Thank you, Bhupesh. And it's wonderful to be in company of stalwarts here. Before we go ahead for any lamellar surgeries, we must do namaste, big namaste to this gentleman, Garrett Mellis, who was instrumental in conceptualizing all these things from DALC to DSEC to DMAC. And without him, possibly, we would not be talking about all such things. Dr. Bharati already spoke about what's the advantage of endothelial keratoplasty. The most important advantage is it's a closed chamber technique, And hence, most dreaded disadvantage of an open chamber technique like expulsive hemorrhage and all those things can be avoided. Also, it can have a faster visual rehabilitation because we are not putting the sutures there, and suture related complication can be avoided. When we call it DSEC, by DSEC, what we mean is Descemet stripping endothelial keratoplasty. And the Descemet stripping part changed a lot of things. Earlier, we used to do endothelial keratoplasty by dissecting posterior stroma, and which had its own irregular surface. And by introducing Descemet stripping by Meles, it became much more easier. In any DSEC procedure, there are two main components which are involved, and one of them is donor preparation, and second one is the tissue insertion. Indication-wise, again, previous speaker Dr. Bharati elaborated this thing, but the important indications in our scenario is pseudophakic bullous keratopathy, Fuchs endothelial dystrophies, which is more common in West compared to us. But yes, we are seeing such cases more often. Failed graft. Cases of CHAD can be treated with DSEC, as well as cases like eye syndrome and post-endothelitis cases. The question arises, when do we do DSEC? When do we choose DSEC over DMEC? Well, let me clarify one thing. Experienced surgeon like Dr. Rajesh Fogla can possibly do DMEC in every case scenarios. But when we talk about mortal souls like us, that we have to think about where do we want to do DSEC and where we can go with DMEC. Now, there are certain donor factors and certain patient factors which would help us to decide when to do DSEC or DMEC. The donor factor, well, if the surgeon is not very experienced in terms of tissue preparation or DMEC graft preparation, which can be sometimes tricky, if the donor is very young, then DMEC becomes really difficult. Old diabetic cases can also have very sticky DM, and it can be difficult. In fact, if you have two donor tissue, and if one of them is very sticky and leads to horseshoe tear or anything, I would be very careful about the other tissue, because it may behave, if it's a other eye of the same person, it may behave similarly. If you have already damaged one corneal tissue, and if you have another tissue left, which is the case, that other eye of the same donor, then I would rather prefer a DSEC over DMEC. The patient factor where the visibility is very poor, or there are glaucoma shunts or aphakic vitrectomized eyes, large defect of iris where the air bubble tamponade may be difficult, disorganized anterior segment, especially in TAS and all those things, where you have multiple peripheral anterior senicae. What happens when you are dissecting these anterior senicae, and when there is bleeding inside, though you can put air bubble to stop the bleeding, but many times the fibrin prevents the opening of the DMEC tissues. In such cases, a DSEC can be a better option. The preparation of tissue wise, we can have manual dissection or the automated dissection. I would prefer automated dissection because what it does, it gives me a very well precise uniform thickness donor tissue. And you can have ultra thin tissue, you can have thicker tissue. Based on what kind of blade you are using, you can have a different tissue. Certain places we do have availability of pre-cut tissues from the eye bank, and even femtosecond laser can be used. However, sometimes femtosecond lasers tissue can have some endothelial damage, which has to be kept in mind. Surgical techniques wise, there are two major part of technique, as I said, donor incision. In donor incision, there are again two ways of inserting donor. One is push technique, using previously what we used to use, taco fold or forceps assisted. Another one push technique is commonly used sheet glide, and endosaver also is one of the automated way of putting the tissue inside by push technique. The pull technique commonest is Busin glide or tan endoglide, or even we can use suture to pull in the tissue. The preparation of DSEC tissue using artificial anterior chamber and the microkeratome. Well, first we mount the tissue while running the saline so that we do not have air inside. Preventing air allows us to have a firm tissue, whereas air is more compressible. So we would like to avoid air. We tightened the artificial anterior chamber, remove the loose corneal epithelium, make a mark so that we can replace the cap there, making sure the pressure is adequate. We mount the microkeratome on the surface. We would like to keep the surface wet when we are cutting so that it does not lead to buttonhole. In a single pass, we cut the anterior cap, and in the bed, we would like to mark the periphery of the edge of the cut so that our punching becomes central to that edge of the cut. We replace the cap on top of it. The idea behind that is it gives a bulk to the cornea. Hence, when we remove the anterior cap of artificial anterior chamber, the tissue bounces back and does not lead to further endothelial damage. After that, the cap and the bed complex is taken on a punch. Whatever punch suits you. Here I'm using Hana's punch. This is a vacuum punch. So whatever punch suits you, you can use to punch the adequate size tissue. I would normally prefer the tissue of 8.5 millimeter size, depending upon, again, the recipient bed. Now, inserting the tissue can be done using different ways. Here, I'm showing you the pull-through technique using tan endoglide. This case had a smaller size anterior chamber IOL put. So my plan was to remove that and measure the size and then replace it with an adequate size AC IOL. Under AC maintainer, I'm doing the Desmet stripping. The same step can be done under air also, but air has to be replaced multiple times because it can leak out. Or else at the side port, you can put dispersive viscoelastic there, making a peripheral iridectomy here. As the previous surgeon had not made an iridectomy, which would be required for ACIL, as well as it would facilitate my DSEC surgery also. After inserting the ACL, now this case was dissected on femtosecond laser. So I'm dissecting that tissue, which is part dissected on femtosecond laser. This is the tan endoglide, and I'm mounting the tissue as it's dissected on the femtosecond laser. The marking had to be done later on. The pull-through technique requires a micro forcep, which is straight forcep. I pull the DSEC tissue inside and then mount my endoglide there. Flip the endoglide, and from the opposite side, I go with, again, micro forcep and pull the tissue inside. Anterior chamber maintainer is then is stopped, and then we put the air bubble and suture the corneal wound, adjust the cornea there. Another pull-through technique using Busin glide. Busin glide is much easier and less expensive, reusable. So Busin glide can be used. Similar way, we go from the opposite side using a micro forcep and place the Busin glide near the wound and pull the cornea inside. Again, the artificial anterior on the AC maintainer is kept on, which helps us to open it up, and then suturing it, the main wound as well as the side put. After putting an air bubble, completes the surgery. The pushing technique using sheet and sheet glide also is very simple technique, where on top of it, we put a cohesive viscoelastic agent, and on that we put the tissue. And then
sorry to interrupt you. We have limited time for each speaker, so I request you to wind it up.
I'll try to
Thank you.
conclude.
Thank you.
In failed PKP, we can do DSEC. We may not do a endothelial or descemet stripping there. Complication-wise, one of the commonest complication is dislocation, and which can be detected on anterior chamber OCT. To conclude, DSEC can be a better alternative to PKP in many cases. Proper case selection may be required. There can be a small learning curve. There are indications where we would prefer to do DSEC over DMEC. Hence, DSEC still has a place in the current practice. Thank you very much.
Thank you, Dr. Himanshu. All the videos were excellent, and I've learned DSEC from you, so it's always nice to see you back. And any questions from any of the panelists?
I think what the last statement, what Himanshu told, that DSEC still has a place. I also agree that DSEC still has a place, because there are certain conditions wherein, many times, which I keep doing, like, badly, traumatized eye with a iris, ACIOL almost touching the endothelium, iris synicate, etc. Then you have to remove it. Then I prefer doing a scleral fixation of IOL, intrascleral haptic fixation. Sometimes the iris is so badly damaged and traumatized that it is irreparable kind of eye is hypotenuse. In such cases, it's better to do DSEC, and ultra thin DSEC is something which is really, a good adjustment between DMEC and DSEC. So I prefer ultra thin DSEC in such complicated scenarios. So
yeah, I have a small question, sir. What is your take on DSEC with ACIOL? Is it equally safe?
Yeah, that's the reason I wanted to show that video. That many times we love to hate these ACIOLs, but they can safely be used, and you surely can do DSEC along with the ACIOL also. Well, I definitely would love to do other scleral fixation also, but ACIOL is equally fine. And I mean, even the long-term outcome. If the proper sizing is done, as Dr. Rajesh said, if many times they've not done proper sizing, the ACIOL is touching endothelium, and that's a bad idea. I mean, that's a poorly done surgery. But if you have done a good job in the sizing, then it works pretty well.
I think if the anterior chamber is deep, then ACIOL is, very useful in such cases. You can easily put it and.
Yeah, so I don't endorse that every time we should use ACIOL. I just wanted to show that it can be done, but preferably if we are able to put a posterior chamber IOL in whichever way suits you, that would be better.
And any role of gas in place of air in these cases?
So I would prefer gas if my tamponade requirement is longer. So if I have tissue where I'm not able to get a very tight anterior chamber with the air, I might use gas. If I have refloated tissue where I have done once or twice repeat air bubbling, then I might want to use gas there. Having said that, most of the time, especially as Dr. Rajesh was saying, ultra-thin DSEC does not require anything much but an air bubble.
And what about PI? You do regularly in all cases?
Yeah, I do. I mean, I do inferior PI in most of the cases, because more so now when we have shifted to DMEC more often than DSEC, it becomes more important to have an inferior PI in these cases. So I prefer, but again, DSEC, if you're able to reduce the air bubble to the size that it's not going to cause any pupillary block, it may be fine to even not do that.
Because I routinely remove air after 1.5 hours, little bit, and never do PI. So
of course, yeah, that's absolutely fine.
Thank you, sir. Thank you so much for the wonderful talk. And the next talk will be by Dr. Praveen Krishna, and he'll be speaking on DMEC, its significance in the era of, DMEC is the new frontier of endothelial diseases. So sir is busy with some other webinar, and so I'll start sharing his video. Just give me a second.
Hello and good morning. I'm going to speak to you today about DMAC. But instead of speaking plainly about DMAC, I'm going to try and share with you why DMAC is a better procedure as compared to DSAC. So there are several reasons why DMAC probably is a better procedure than DSAC. And these reasons are listed here. It is anatomically more natural. You have a lesser risk of rejection because of lesser steroids. And you also have better visual quality in these patients, more predictable IOL power, faster visual recovery, and better refractive predictability as well. So let's look at each of these individually. So from the point of view of anatomically being more natural, you'll see that most DSAC surgeries result in good visual outcomes. But if you look at the OCT of DSAC patients, you will see that this is an addition procedure where you add more tissue, and you always will have some change in the anatomy. If you contrast that with DMAC, DMAC removes the Descemet's membrane and endothelium and replaces just that. So anatomically, it is much more natural as compared to DSAC surgery. The second and probably the most important reason why DMAC probably scores over DSAC is because of rejection rates. DMAC has rejections about 10 times less than DSAC over a period of 5 years. And this is with low doses of steroids as well. And because of this, you also can consider doing DMAC for patients who have failed DSACs or failed keratoplasties, and you usually will have better survival in these patients as well. The other reason is better visual quality. There is a higher percentage of patients after DMAC surgery who get a vision of 20/20, and you also have patients who reach visual acuities as high as 20/16 as well, which you will not see with DSAC surgery. IOL power calculation is usually not as predictable after DSAC surgery, where there is an average shift of 1.5 diopters towards the hyperopic side after DSAC, which tends to come down with time, and so there is a shift in IOL power. Now, if you compare that with DMAC, the average shift is only about 0.5 diopters, and you have a very early stable IOL power and refractive error in patients after DMAC surgery as well. DMAC patients also recover vision much faster, and you will see that compared to preoperative corneal edema, like you see in this patient of PBK, in day 1, you'll see a large amount of the corneal edema already has come down, and by day 3, most corneas will already be clear, and you'll have excellent visual recovery in these patients as well. The last one is refractive predictability. In DSAC surgery, the smallest incision that you can use to deliver a graft is about 3.5 to 4 millimeters using a Pusen slide or a maculoso inserter. And this causes a significant shift in astigmatism as well. Might not be our primary problem, but then this certainly is a consideration where you're trying to give as good visual outcomes as possible. Whereas for DMAC, you can deliver a graft from an incision as small as a typical cataract incision, and these incisions do not cause as much astigmatism as patients who have DSAC surgery cause. There are some differences in the surgical technique as well. For example, in donor preparation, DSAC, you have a number of methods. Most commonly used is microkeratome right now. In DMAC, you have pre-stripped tissue available from a number of eye banks in the West, but also now when you can prepare your own tissue in the OR, generally tissue preparation is very quick, does not use expensive machinery, and also results in very high success rates of tissue preparation. In fact, I would say that tissue preparation rates in DMAC surgery after an initial period of training will approach 95% plus. And you using the no-touch technique that I'm demonstrating here will get a DMAC graft with exceptionally good endothelial cell quality as well. What about Descemet stripping? In DSAC nowadays, we tend to not strip the Descemet if there are no pigments or cuttae, and you will also strip in a smaller area of about 6 to 7 millimeters so that there is no overlap. In DMAC, this is different because you will always want to strip the Descemet's membrane in an area that is larger than the size of your graft. So typically about 9 to 9.5 millimeters of Descemet strip. And it's also very important not to leave any Descemet's behind because you don't want graft detachments in these patients. Incisions in DSAC surgery tend to be longer than normal so that you can ensure that you get a good air bubble and you have some overlap of the internal lip. Whereas in DMAC surgery, you tend to have shorter incisions so that the graft does not overlap the internal ostium of these incisions. And that's the reason why when you make your side ports, or even when you make your main incision, you try to have them as short as possible. Marking in DSEC surgery, again, is nowadays unusual unless you're right at the beginning of your start learning curve in DSEC surgery, and it is not required to mark the DSEC graft because orientation is usually maintained. Whereas in DMEC surgery, it is desirable to mark your graft because sometimes telling orientation in a cornea that is a little hazy might be difficult. Loading of the graft in DSEC surgery, again, is usually with the endothelial side up, and you can load them on different devices and then deliver them inside the eye by separating the anterior and the posterior lamella, as you can see here on the Busen slide. Whereas in DMEC surgery, most loading is done using a no-touch technique where you just aspirate the graft into a glass tube and then deliver it inside the eye. Graft delivery as well, DSEC has a number of techniques to deliver grafts, but in DMEC, the primary mode of delivering a DMEC graft is using a glass tube inside the eye. Manipulating the graft inside the eye in DSEC surgery can be done by direct manipulation by touching the graft and moving it around so that you're happy with the graft opening up, and also with centration. You cannot do this with DMEC, and most maneuvers with DMEC are using fluid and from the surface of the eye rather than from inside the eye. Once you have a DMEC graft positioned adequately, most cases you will be able to open the DMEC graft quite successfully by a series of taps on the surface, by opening up the graft in the right orientation, and also to center the graft, and also unfolding the graft using maneuvers that you will do from the surface of the eye. As you can see here, I'm just using 2 cannulas to tap and try to open up the graft using fluid waves to open up the graft rather than direct manipulation. Attachment in DSEC is usually quite good and detachment rates are low, whereas in DMEC surgery, you need to ensure that you have a complete airfill and ensure patient positioning so that you have good graft attachments as well. We don't use C3F8 or SF6, and air usually will suffice in almost all your cases of DMEC surgery. So when you compare how DMEC does according to DSEC, you will see that DMEC is a superior surgery as compared to DSEC from the point of view of patient outcomes. But there are several reasons why it is so, because it is anatomically more natural. There's lesser risk of rejection, so you can use lesser steroids, better visual quality, more predictable IOL power, faster recovery, and greater refractive predictability as well. There are some difficulties during transition, and you might need about 10 to 15 cases to become a very good surgeon in DMEC in your initial learning curve. But there are a few cases where you would still consider DSEC, where you have very poor visibility, patient has comorbidities that does not allow them to lie flat, extensive pass, if you have a poor posterior graft close junction, and where DMEC really would not make a difference to the point of view of visual acuity of the patient's eye. Thank you very much.
Thank you, sir. It was a wonderful talk. So any comments from any of the faculty? Himanshu, sir? Hello.
I think Praveen took up everything nicely. The difference between two surgery. Basically, the dynamics of fluid in the anterior chamber is the most important part in DMEC, and which is very, very different from anything we do in DSEC. So even if we are experienced DSEC surgeon, in the beginning of the DMEC surgeries, we may actually get confused. We may actually suffer with such kind of thing that tissue is not behaving the way we want it, because it's very different dynamics what we have to do. Thankfully, with many authors and many surgeons who have elaborated upon this topic, that based on what configuration we get, what kind of manipulation we do, has made the life much easier. Earlier, we used to do same thing for everything, and then the scroll would not behave where we would want it to behave the way we want it. And now we know that based on the configuration of the DMEC tissue, we will do different things, and that certainly helps. I would still say that the donor tissue preparation is most important. Your donor selection is extremely important. Very young tissues are very, very sticky, and I have done PDEX for them, and it actually works pretty well there. Whereas very old tissues are very friable, and they just don't close. They just keep opening up also. So selecting a proper donor is very important. And initial period, I would certainly advise to have a backup tissue for DSEC, because if you're not able to do DMEC, a DSEC can certainly be done. But rest everything Praveen has very nicely elaborated.
So I just have a small question, sir. When is the right time to start DMEC surgery for young surgeons?
As I said, there is no relationship. But I mean, it's the only relationship is that if you can't do DMEC, then you have to fall back on DSEC. So you should know DSEC that way. But otherwise, both of them are pretty different. So you surely can go ahead and start it as early as possible. But remember that if you can't do DMEC, you should have some backup plan. And if you're not good at DSEC, then it becomes a little difficult. That's the reason why transition can always be better.
Thank you, sir. Thank you so much for the good discussion. And the next talk, I'll be there. And let me share the screen. So I'll be speaking on femtosecond laser-assisted keratoplasty. And this technique also I learned from Himanshu sir. And I've seen him operating around 7-8 years back. And now I'm doing quite a few femtosecond keratoplasties. No financial disclosures. So these are the weapons of ophthalmologists. We all know that, but it won't be wrong to say these are the old weapons of ophthalmologists, because now femtosecond laser is there to perform most of these steps that we are using: knives, blades, and crescents, keratome, everything. So femtosecond is an excellent cutter in the cornea. We can perform any incisions, any shape, or anything in the cornea. So femtosecond laser is a photodisruptive infrared laser with a power of 10 to the power minus 15. It works, it is based on the principle of photodisruption, in which thousands of laser pulses are connected together in a raster pattern to define a resection plane. Then this gas and water are absorbed or liberated to perform a resection cleavage plane. So we all know that manual keratoplasty is time-tested, most successful organ transplant. Although there are different surgical challenges like the problem of trephination, the problem with the sizing, the ledge issues, then suturing, the correct technique, the appropriate tension needed for any case, high astigmatism in post-operative period, high endothelial cell loss, and then delayed visual rehabilitation. So to overcome all these challenges, now we have a another important thing in manual keratoplasty is that it only provides a classical vertical incision. These wounds require relatively tighter sutures to withstand the effect of intraocular pressure, which leads to high astigmatism and healing of at least 1 year. And after that also, the chances of wound dehiscence after suture removal is up to 4% of cases. So to overcome all these problems, now we have femtosecond laser. It has the ability to perform incision of any angle at various depths within the corneal tissue. It permits full thickness graft with peripheral lamellar wound configuration. It works with greater precision, in finite control, and in automated manner. There's a minimal donor tissue manipulation with femtosecond laser, and which causes less endothelial cell loss during the procedure. Another advantage with femtosecond laser procedures are it provides greater surface area because of its customized shapes. A manual PKP wound is vertical, as I've discussed. The variation from this type of wound is not possible with manual surgery, but when we go with femtosecond laser, we can make any shape like top hat, mushroom, zigzag, or any other configuration which is needed. So how to choose which kind of incision suits for which surgery? So for example, top hat shape configuration, it removes lesser of the stromal tissue and more abnormal endothelial tissue. So it would be good to do in cases of pseudophakic bullous keratopathy. In cases of keratoconus, where the corneal stroma is a problem, mushroom shapes works well because it removes abnormal stromal tissue and saves more endothelial tissue. Whereas zigzag shape, it provides excellent wound seal because the angled edge provides a smooth transition between the host and donor tissue. So how femtosecond laser cut the cornea? So basically the femtosecond laser cuts in 3 planes. But first it makes the posterior side cut, which is a cylindrical cut from the anterior chamber into the stroma. Then it makes the lamellar cut, which is a planar ring-shaped cut parallel to the anterior surface. And the last cut is the anterior side cut. It is a cylindrical or arcuate cut from the stroma proceeding anteriorly to the epithelial surface. So because of this multiple planar cuts, the wound seal is always better. So there are studies which have compared femtosecond keratoplasty results with a conventional penetrating keratoplasty, and this was in keratoconus. And the study have shown that the BCVA was better in all femtosecond cases, and endothelial cell loss is also lesser in femtosecond group. And they found that it is a safe and better procedure than the conventional PKP in keratoconus. So there are different platforms which provide the opportunity to perform femtosecond keratoplasty. And this was one of the video which I performed in Corneal scar case. With the advanced machines where we can play with the energy, we can perform femtosecond laser with the in corneal scar cases also. And like this machine is the intraoperative OCT, so you can see where you're going to cut. And this is the anterior chamber. You have to mount the cornea on this, remove the loose epithelium, and then apply suction. And once the suction is complete, centration is fine. Again, look for the OCT pictures, make the necessary adjustment, and then do the resection. You can see the gentle peeling of the tissue is required. No cutting is needed. This is another case where you can see the nice ledge, symmetrical. Suturing is very simple in cases of femtosecond keratoplasty because the ledge, the donor tissue nicely sets in with the recipient. You just have to put small sutures, and suture numbers can be less. You don't need to put 16 sutures always. If the graft size is less than 8 millimeter, 12 sutures works equally well. The length of the suture is smaller than the manual keratoplasty. And people have also started using glue with few sutures in some of the cases. You can see the nice opposition of wound and the donor and the host. And this is a photograph of the ASOCT post femtosecond PKP. The wound transition between the host and donor is clearly visible. You can see the nice transition is there, which shows that the position is excellent with femtosecond keratoplasty. This is another paper which talks about femtosecond role in lamellar keratoplasty. Dr. Rajesh has already covered. It works very well with the anterior lamellar keratoplasty cases. So this was one interesting case of recalcitrant epithelial growth, where after several maneuvers, the epithelial growth came back. So we performed femtosecond keratoplasty for this case. So in such cases, femtosecond is very useful because intraoperatively you are seeing everything, that you're not missing any scar or any epithelial cells. So you can cut accordingly and modify intraoperatively. Another important factor in femtosecond keratoplasty is that you don't need to take an oversized graft. In most of the cases, same size graft works well. So this is the donor. You just gently have to lift up. And this is a post-op photograph of the same patient, and we can see nicely attached graft. This is another interesting case of central corneal scar in which the periphery is clear. So we went ahead and planned a hemi-automated lamellar keratoplasty for this case. And after measuring the clear zone, the cut pattern is designed on the femtosecond laser. In this case, what femtosecond laser, how it helped in this case, it makes a planar cut around the corneal opacity. So we get a uniform plane all around it. So it's very easy for us to enter with the sharp crescent and stay in the same plane, because from all around you are in the same plane. So gently we have dissected this tissue. So this is a hybrid technique with femtosecond laser as well as some manual steps. And then this is the donor tissue of the same size. You gently have to remove the epithelial bridges with the help of Sinski and then lift the tissue up. Most of the time there are no tissue bridges because of the appropriate use of energy. And then suturing is done. And This is a post-op photograph of the same patient. You can see the nicely attached graft, no overriding or any haze. And femtosecond enabled DLKs are also being done from last 1 decade. But till now, the femtosecond assisted DLK was in that the AIOC or pentacam used to be done to measure the thinness spirometry. And then we have to cut less than 100 micron or 80 micron up to the thinness spirometry. And then we try big bubble, or if the interface is clear, leave the remaining stroma behind and suture the graft. But with the newer femtosecond laser like Zimmer Z8 machine, we have the added feature of making a tunnel for air injection. So this tunnel, you can play with the length, the angulation, the width according to your cannula size. So this step makes this femtosecond laser more predictable. This DALK procedure more predictable. The chances of getting air big bubble is quite high. This was another case done on this machine. So this is a lamellar cut made with femtosecond laser. You can see this is a tunnel made with the femtosecond laser. And then air is injected in the same plane. Chances of perforation is extremely rare with this software. And then air is injected, and then the dissection is done. The graft is sutured. So now femtosecond laser has come with the inverse ultra thin desec technique also with the Zimmer Z8 machine, where you have to mount the cornea up endothelial side up, and they claim that if you press it with the handset with the machine, it will not damage the endothelium if you go vertically. And then it makes 2 pockets and a lamellar cut. Then you have to open this pocket with a blunt spatula, and then trephination is done, and this lenticle is used for the desec surgery. I've personally not done this inverse ultra-thin desec, but maybe in future I'll perform this also.
So sorry to interrupt you, but the time is up, so I would request you to please wind it up.
So in conclusion, the femtosecond laser gave new dimension to keratoplasty techniques, from PK, ALK, DLK to DSEC. All the surgeries, it has its role, and the early visual rehabilitation, less astigmatism, and ease of doing surgery are the main benefits of femtosecond keratoplasty. Thank you. Any comments from Rajesh sir, Himanshu sir?
No, very nicely shown. And the one that you showed, the hybrid technique, I was just wondering that initially in the earlier case, you showed that with, obviously we can, work with the energy level, and maybe we could penetrate that scar as well to a great extent. So I was just wondering what was the need for the hybrid technique in that?
So it was around mid-stromal scar. So,
okay.
So the concept is that if you go very deep with the femtosecond laser, the cutting is not very
smooth. If you go deep, the femtosecond laser doesn't work.
Cutting is not, and the scar is very dense, so you're not sure whether it's going to cut or not. Yeah, so it gives a plane all around 2 millimeters, and then you have to just go there. So it's
I completely agree with you. Yeah.
Thank you, sir.
That was very nicely demonstrated, and the advantage of femtosecond laser is the edge apposition is
superb in all the cases.
It's very good.
So that's very true. So if no further questions, so we'll conclude this interesting webinar. And thank you so much, all the faculties. Thank you, Rajesh sir. Thank you, Himanshu sir. Thank you, Bharti sir. And
thank you, Dr. Bhupesh.
Thank you, Dr. Bhupesh.
Thank you, sir. And we'll leave this meeting now. Thank you.
Thank you.
Thanks. Bye.
Bye. Bye.
Thank you, everyone. Thank you so much for joining us for this session. It was a very informative session from all of you. Thank you, all the doctors, for